Thank you very much, Mr. Chairman. Okay, in the last session I talked about radioiodine ablation after the surgery, and after me, Dr. Khalil spoke about follow-up of the patients and especially finding the recurrence and metastasis. The question is how we can treat the metastasis of well-differentiated thyroid cancer. We can perform radioiodine therapy for treatment of local recurrence, regional lymph node metastasis, and distant metastasis if surgical resection is not possible or there is a high risk for operation and we cannot send the patients to the surgery. Here is the results of various modalities of treatment of well-differentiated thyroid carcinoma. It's a retrospective study of 1,600 patients, published 92, and they concluded treatment with radioactive iodine was the single most powerful prognostic indicator for increased disease-free interval and also survival as well. Okay, the recurrence rate. In the low-risk group, we have 10 to 30% recurrence, and the high-risk group, about 20 to 50% of patients develop a recurrence. The classification of the recurrence is as follows. We have local recurrence, I mean the thyroid bed is about 28% of the cases. Regional recurrence, it means lymph node metastasis in about 53% of the patients, and locoregional recurrence, both of them together in 6%, and also distant metastasis in about 13% of patients. Considering central and lateral neck recurrence, we have residual tumor in thyroid bed, invasion to trachea, esophageal, larynx, and vessels, and also pretracheal nodes, mediastinal nodes, and as you see here, in 80% of the cases, nodal recurrence is in paratracheal nodes, and in about 23% of the cases in different levels of the neck. How we can detect a local recurrence or metastasis? First, clinically. We measure the thyroglobulin, and the best detecting system is the ultrasound. It means we perform ultrasound regularly and we measure the thyroglobulin level. And if we find a lymph node metastasis or a local recurrence, we can perform after that a radioiodine scan for evaluating the whole of the body. The radioiodine scan can be performed with different radiopharmaceuticals. I'm going to show you, and also for some specific cases in whom we think they have iodide negative metastasis, we can perform also PET CT scan with different radiopharmaceutical. Iodine 131 is one of the radiopharmaceuticals which we perform it in the cases in which we have lymph node metastasis or other type of metastasis here, where a patient with a miliary lung metastasis. You can perform also a SPECT CT. With a SPECT CT, you increase the sensitivity and also the specificity of your scan. You can find the lymph node metastasis, and you can anatomically define where exactly are these lymph node metastases. It helps the surgeons for a better surgery. Iodine 123 is another option for scanning these patients. Is comparable to high-dose iodine 131 scan, offers excellent image quality as a diagnostic agent, and it avoids disadvantages such as stunning before treatment and delivery of a high radiation dose to patients. According to these both studies, you see a good correlation rate between iodine 131 and iodine 123, about 87%. Here, one example, a patient with papillary thyroid carcinoma and multiple metastases. You see here both scans, iodine 123 and post-treatment scan look almost same. You see, but with iodine 131, in majority of cases, more lesions. But we have also negative scans with iodine 123, like in this case with papillary thyroid carcinoma with a thyroglobulin of 24 nanogram per milliliter. And in ultrasound, as you see here, lymph node metastasis, iodine 123 was negative, but we performed the treatment and iodine 131 showed a very good accumulation in the lymph nodes. But there are also some limitations for iodine 123. It's costly, has a short half-life. It means you cannot perform late scans. And as I said, sometimes more hotspots you can find in iodine 131 compared to 123. Iodine 124 PET CT may be a better option because it is PET, you have a better resolution, you have better sensitivity, and you can perform also dosimetry. Could be a good option for performing a diagnostic prior to treatment planning. Could be an operation, could be a radioiodine therapy. Yes, as I mentioned, if you find radioiodine positive metastasis, especially lymph node metastasis or local recurrence, the first treatment choice is the operation. And if an operation is not doable because of other metastases or because some contraindications for operation, you can perform radioiodine ablation. Unfortunately, there isn't any recommendation for dosimetry or empiric doses calculation from ATA. There is insufficient data to recommend recombinant TSH stimulated radioiodine therapy for all patients, but for some patients you can do that, especially patients who suffers from depression. And we don't know exactly if lithium can help in such patients, because if you perform the radioiodine therapy under lithium, because of lithium, the residence time of iodine will be longer compared without lithium. American Thyroid Association recommend for pulmonary micrometastases radioiodine ablation with 100 to 200 millicurie in 6 to 12 months intervals, as long as there is uptake. In Germany, we treat the patients more aggressively with 150 to 300 millicurie, and they recommend also the same dose for macrometastasis. Here one example from our department, a 27-year-old female with papillary thyroid carcinoma and miliary lung metastasis. After 5 treatments with a cumulative dose of 1.5 curie, in about during 2 years we did the treatments, and you see the scan after the last treatment. What are the recommendations for bone metastasis? First, radioiodine therapy of iodine-avid bone metastasis has been associated with improved survival. But as you know, the patients with bone metastasis has poor prognosis, and often we cannot treat the bone metastasis completely with radioiodine. The radioiodine activity administered, the radioiodine dose is recommended by American Thyroid Association is about 100 to 200 millicurie. In this case, in Germany, we treat the patients with 300 millicurie. Completed surgical resection of isolated symptomatic metastasis has been associated with improved survival and should be considered, especially in patients younger than 45 years old with a slowly progressive disease. What we can do for other metastases, for example, CNS metastases, first, complete surgical resection of these metastases. Second, external beam irradiation, and also you can perform radioiodine therapy. And if you want to perform radioiodine therapy, it should be prior to external beam irradiation and with concomitant glucocorticoid therapy. The European Association also has a guideline regarding metastasis of thyroid cancer. They have definite indications. First, for unresectable iodine-avid lymph node metastasis, where one or more of the following is true. First, morphological imaging does not reveal location. Surgery is high risk or contraindicated, and distant involvement is present that would indicate radioiodine therapy anyways. Secondly, for iodine-avid pulmonary micrometastases, especially before they become visible on CT. And third, non-resectable or partially resectable iodine-avid pulmonary macrometastasis. For also non-resectable or partially resectable iodine-avid soft tissue metastasis, they recommend performing radioiodine ablation. And there are also some optional indications. First, recurrent iodine-avid lymph node or distant metastasis as an adjuvant to surgery. It is what we do in Germany a lot. We send the patients to surgery, the high-risk patients, and after that we perform an adjuvant radioiodine treatment to kill the residual micrometastasis cells. Unresectable iodine-avid lymph node metastasis, where one or more of the following is true: size is small and involvement includes numerous nodes or is widespread. And also non-resectable or partially resectable iodine-avid bone metastasis, especially when they are symptomatic or threatening vital structures. What can we do for patients with high thyroglobulin level but negative whole body scintigraphy? It's a very difficult thing. American Thyroid Association recommend one-time empiric 100 to 200 millicurie radioiodine treatment if thyroglobulin is more than 10 after withdrawal of hormone therapy, or under recombinant TSH is more than 5, and no imaging evidence of disease is there, and they recommend no further radioiodine therapy if post-therapy is negative. It means just one time, but if it's positive, you can perform more therapies and continue as long as there's uptake. If still thyroglobulin below above values and no structural disease can be found, you have to do just follow-ups of this patient. We don't have to forget the suppression therapy with L-tyroxine is one of the most important treatments of our patients. Here in this study, published 96, they compared two groups of patients. In one group, they received L-tyroxine as a suppression therapy. It means TSH level was under 0.1, and in the other group, TSH was more than 1. And you see here the relapse-free survival is significantly better in this group, in which the TSH was below 0.1. But in another published study in 98, they had more patients. They showed this TSH suppression is especially important for high-risk group of patients, and there is no difference regarding progression-free survival between low-risk patients if you suppress the TSH level. Therefore, the recommendation at the moment is for high-risk patients or intermediate-risk patients, L-tyroxine therapy with a TSH level under 0.1, and for low-risk patients 0.1 to 0.5, and for patients with persistent disease you have to suppress the TSH. And for low-risk patients who are disease-free, it means after radioiodine ablation, and normally we perform in Germany 3 to 6 months after ablation a radioiodine scan with 5 to 10 millicurie, and if this scan is unremarkable and thyroglobulin is also negative, you don't have to suppress the patient's TSH level can be between 0.1 to 0.5. But what can we do for patients who have metastases and the metastases of them are iodine negative? When radioiodine uptake is significantly reduced or absent, suggesting loss of differentiation of neoplastic cells. Patients without sufficient radioiodine uptake in the tumor cells have a significantly lower survival rate if distant metastases are present. I show you the result of this study from Durante 2006 was published. And you see here in patients with radioiodine positive metastases, the 10-year overall survival was 60%, median overall survival about 15 years. And in radioiodine negative patients, the survival rate was significantly lower than radioiodine positive patients. We can try to redifferentiate these metastases with vitamin A, with retinoic acid, or Radioiodine Therapy. We performed in Germany for about 10 years this therapy with vitamin A. In 40% of the cases, we had success. And it is our protocol for patients. We gave the patients 1.5 milligram per kilogram body weight daily retinoic acid at least 6 weeks prior to radioiodine diagnostic or therapy. And here one example from our group. Prior retinoid therapy, a patient with metastasis, but iodine negative metastasis, as you see here in this scan, and after retinoic acid therapy, it means you can try to redifferentiate the metastasis of these patients. We have but another radiopharmaceuticals for the diagnostic of iodine negative metastasis. Technetium, MIB, tetraphosphamine, and thallium have been used many years. At the moment, we have FDG PET CT is actually gold standard for a diagnostic of iodine negative patients. And also we have somatostatin receptor scintigraphy and also somatostatin receptor PET with gallium-68 DOTA-TOC, which are also very important options. Here one example, a patient with iodine negative metastasis, and you see here in FDG PET a lot of metastasis with high glucose metabolism. FDG uptake by differentiated thyroid carcinoma is associated with more aggressive biological behavior of the tumor and the worse prognosis, and it is the case also with other tumors like HCC or melanoma. Here you see the results of different studies. The sensitivity and the specificity of the PET CT in such cases is more than 90%, especially if you use PET CT. Okay, today's all of the departments have a PET CT camera. Here one example from our group, a patient with oxyfuel cell follicular thyroid cancer, PT3 tumor, initially M0, and 2 years after radioiodine ablation, the patient showed a thyroglobulin level elevation. The radioiodine scan was negative. We could find in our ultrasound this lymph node metastasis, but as you see here in FDG PET, you have another hot spot over there. It helps the surgeon to have a better surgery. And normally in Germany, a lot of surgeons recommend in such cases a whole level lymphadenectomy instead to operate just these foci. When we can perform a PET CT, there isn't any uniform recommendation. A lot of researchers wrote from a TG more than 10 nanogram per milliliter, the sensitivity of FDG PET CT may be higher than if the thyroglobulin is less than 10. Should FDG PET CT be performed after withdrawal of T4 or under recombinant TSH is also unclear. Off-therapy state seems to improve sensitivity, especially in the presence of detectable but low TG level, more than 1 and less than 10 nanogram per milliliter, and small metastasis with low metabolic activity under levothyroxine regime. Here one example from our department, how can FDG PET CT help the surgeons. This patient with follicular thyroid cancer had already received 600 milliculi radioiodine therapy because of different metastases. He had 3 times local recurrence till 2011, and after the last operation, everything was good. Here, the scan of 2011, you see 2 metastases, paratracheal metastases. They were operated, but the patient come to our department with a thyroglobulin 5.5 under TSH suppression. We performed again a PET CT scan, and you see here another metastasis. It is not the same metastasis. I can show you here. It is a metastasis in the trachea, and the old metastasis actually were operated, new developed metastasis. For such cases, if they are not operable, at the moment we have new therapies with thyroid kinase inhibitors. There are different medications like sorafenib or patsopanib, zunitinib. They showed actually a good partial response in about 20% to 30%. We don't have to forget these therapies is for patients who don't have any other treatment option, and 30%, 20% partial response is actually good. Here, one example, a 54 years patient with follicular thyroid cancer, actually with Hertel cell tumor, 2007 was the first, has been diagnosed. And you see here a lot of lung metastasis and lymph node metastasis. This is the FDG PET CT scan. And the patient was treated with patsopanib, and you see here the TG was, which was 24, decreased to 2.5, and you see here the high glucose metabolism was also has been also reduced to this state. We can also perform somatostatin receptor PET or SPECT. Because all subtypes of somatostatin receptors are located in different density on the surface of thyroid gland, especially somatostatin receptor type 3 and 5. We have another different possibilities for scanning these patients. The choice is gallium-68 DOTATOC PET CT. As you see here, papillary thyroid carcinoma and follicular thyroid carcinoma, they have a lot receptors 3, 4, and 5, and Hertel cell and medullary thyroid cancers, the majority of them have somatostatin receptor type 2. It means just 50% of thyroid cancers can be detected by octreotide. Here one example, a patient with iodine negative metastasis with high thyroglobulin, 32 was a thyroglobulin. You see here FDG PET was negative, but gallium DOTATOC PET was positive. The doctors decided to do nothing because at this time gallium DOTATOC PET CT was not the standard of procedure. 15 months later you see more extensive metastasis in gallium PET CT. FDG was negative. And this flip-flop phenomenon can be seen also here between iodine and FDG, iodine negative, FDG positive, and in this case also somatostatin receptor positive. You can perform radiopeptide therapy for such patients. The results of treatments are not very good actually, as you see here with different, with yttrium-90 and also with indium. They try to treat these patients. In such patients, they could have a stable disease, but as I said, the results are not very good. Thank you very much.